form presentation, and doesn't look like we have any. We have one person trying to join. When we clear out the waiting room, then we'll start the meeting. Okay, I'm going to go ahead and start us off by handing this over to Michelle Probert. She's the Director of MaineCare. Thanks, Michelle.
Jessica, as Jessica said, Michelle Probert, MaineCare Director. I use she, her pronouns, and thank you all for being here this afternoon. There have been discussions for quite a number of months and probably years regarding to the fact that our hospital reimbursement methodology has been outdated for a while. And so we really are excited to join with you here today to talk about the work that we have been doing in order to update the methodology. Services that you provide at your hospitals are critical to the state of Maine, and we thank you for those services. And along with other MaineCare services, it is our objective to make sure that we have a reimbursement methodology that is up to date and stays up to date and ensures that you receive the reimbursement you need to continue to provide those services, and that also emphasize the quality of those services. So that's it for me. Jessica, do I turn it back to you for introductions?
Yes, please.
Great.
At this time, I'm going to ask our presenters and their backups to introduce themselves. I'm going to start with Steve, please.
Thank you, Jessica. And thank you, Michelle, for having me here today. My name is Stephen Obley. I'm with Burns & Associates, a division of Health Management Associates. We've been contracted by the state to assist with the hospital rate reform initiative here. And part of that initiative is reviewing the reimbursement to hospitals and looking at alternatives for the state. And so today, I believe we're going to be talking about the inpatient stuff. So look forward to getting there. Thank you, Jessica.
Thanks. David?
Good afternoon, everyone. I'm David Jorgensen. I'm the Director of Data Analytics and Rate Setting for MaineCare, so I oversee the rate setting unit.
Dwayne?
I'm Dwayne Parsons. I'm the Acting Manager of Rate Setting.
Julie?
Hello, everyone. I'm Julie Scott. I'm a policy writer with MaineCare on the Special Projects team.
And Derek?
Good afternoon, Derek Grant. I'm a manager within the policy unit and work with Julie.
Thank you. As Mandy pulls up our slide presentation, I'm Jessica Levesque, the project manager on the rate reform team. I use she and her pronouns. I would like to encourage everyone to introduce themselves in the chat during the presentation. It's helpful for us to know who's on the call. I'd like to remind everyone that we are recording this presentation, which will be saved on our rate reform website. I will post the website link in the chat, so you'll have access to this information perhaps this afternoon or as early as tomorrow morning, and then there you won't have to wait for the e-notice that goes out with the links. We're going to ask you to hold all questions until we're done with the presentation. There will be a time for you to ask questions about this presentation at the end. Next slide. What we're going to focus on with our presentation today is we're going to review rate practices that are currently in place for inpatient acute care in the rehabilitation hospitals. We're going to examine the challenges and the concerns we have that exist with the current reimbursement model, introduce a draft reimbursement model with a planned effective date of 7/1/24, and discuss some reasoning behind the draft methodology and the relevant assumptions. Next. So our agenda today includes the introductions, which we've done, the rate determination process, current methodology, draft inpatient methodology and peer groups, Medicare diagnostic relative group, which we know as DRG weights, inpatient outlier payment policy, discharge and readmissions, days awaiting placement, topics for future meetings, and our next steps. As you see, we have a lot to accomplish. Next slide, please. This slide talks about our rate determination process. The rate determination process can be found at Title 22 MRS subsections 3173J. And it includes some of the following information. It sets a schedule for regular rate review and adjustment, for annual updates to benchmarked off of Medicare and other payers. For non-benchmark rates, the department annually develops a schedule of rate determination for the coming year, and rates not being redetermined per schedule receive annual cost of living. It ensures review of relevant state and national data to inform rate amounts and payment models. It formalizes a clear and transparent process for our rate determination, which includes meetings like today for stakeholder engagement and public presentation of draft rates, which we will be doing at a later meeting. An opportunity at that time would be for written comments, and that the department drafts responses to the written comments and posts them on our website. It also established a rate system subcommittee to the MAC, and which is the and establishes the tab. Next slide. Thank you. We always think it's helpful to show kind of the process that we go through, and that's what our model is below. The stakeholder kickoff meeting, there's data collection, rate model development, draft rates, presentation of our draft rates, public comment, finalization of rates, and then our rule proposal and adoption. Though this is our generic model of how we go through the process, every rate determination has some flexing in extra steps that are taken. In today's rate determination process, we're having our meeting. There'll be additional public forums. And in an additional meeting, we'll present the draft base rates and the reimbursement methodology. There will be the comment period, review of responses, and we are targeting 7/1/24. Next slide. Okay, at this time, I'm going to hand the presentation over to Michelle.
Great, thanks, Jessica. Usually my cardinal rule of PowerPoints is to have font that people can actually read. And I'm usually a stickler for that, but this is an exception to that rule. And it is because in part, it was a challenge to myself to see if I could summarize our hospital reimbursement methodology on a single slide. I do use this at a regular basis as a cheat sheet to remind myself of the different components of our hospital reimbursement methodology overall. Believe it or not, despite all the boxes and the font size, it is actually a high-level summary. This does not cover all of the aspects of our overall hospital reimbursement methodology. So we could fill it up probably with footnotes and additional bullets. So why do I show this slide? I show this slide in part to recognize the fact that it is very complex. Anybody who works at any of your hospitals in hospital billing, those of us who work at MaineCare, know that there are a lot of details and it can sometimes feel like a bit of a black box. I will also note that there's a lot of differences depending on the type of hospital, subcategories of those hospitals, inpatient versus outpatient, facility costs versus physician or professional costs. Some of those aspects are common to other payers' hospital reimbursement methodology as well. So MaineCare Medicaid is not alone in having complicated reimbursement by any means. You can see, if you can see some of the font on this slide, that for certain services, we rely on diagnosis-related groups or DRGs, inpatient in particular, but not across all hospitals. And for certain costs, we also still rely on cost settlement. The percentage of cost settlement that we settle to, again, varies depending on whether it's inpatient, outpatient, the different kinds of hospitals, as well as professional or facility. It is not always clear as this methodology has evolved over the years with input, obviously, from MaineCare policy and leadership, as well as from the legislature. It is not always clear the rationale for different criteria or for different percentages that you can see in different parts of this overall methodology. The rationale and also the data that is behind the differences in this methodology is not always clear. I will also note that oftentimes when I hear about MaineCare reimbursement, we don't always hear about supplemental payments. Those payments are significant, especially during the pandemic. They were a lever that the state had in order to be able to assist hospitals with critical needs during that time. So supplemental payments are not subject to cost settlement. They are not tied to the current year or more real-time provision of services in terms of volume. We do have a sub-pool, if you will, of supplemental payments that are tied to value-based care. Right now, the quality measure focuses on the provision of primary care. With that exception, the supplemental payments are also not tied to quality outcomes. So again, this is a very high-level view of overall hospital reimbursement. Today, we are focusing in, you can go to the next slide, Jessica. And to start, we are just looking at the inpatient side of the equation, and within inpatient, we are just looking at the, quote, facility-related costs or non-professional, non-physicians side of the equation. And we are specifically looking at acute care hospitals as well as rehabilitation hospitals. We currently have one rehabilitation hospital in the state of Maine. Okay, so this slide just covers what we are doing currently. Stephen is going to be talking about our proposal for moving forward. So as I noted on the last slide, for acute care hospitals, we use a DRG system. I will call out that the DRG weights that we use right now were calculated to be MaineCare specific, and they were calculated over a decade ago. So they are certainly out of date at this point. Within the system for acute care, we do cost settle capital costs as well as graduate medical education costs at 100%. For our rehabilitation hospital, we have a set discharge rate for all discharges, and that discharge rate was calculated, I think it was about 5 years ago, has not been adjusted since that time. Similar to acute care, the capital and GME costs are settled at 100% for the rehabilitation hospital. And then I will note that there is an outlier payment methodology. I'm not going to read out the formula there because it's a little bit confusing, at least for me. So I have my own interpretation of what the formula means in case that is easier for folks. So the concept of outliers, I'm sure folks are aware. We certainly have patients who can have catastrophic circumstances and cost a lot more than a typical patient. And it is fairly common practice across different hospital reimbursement methodologies to have a method of accounting for those outlier cases. The current methodology, we look at an outlier threshold amount. That outlier right now is actually calculated specific to each hospital. And then the difference between that threshold amount, we look at an estimate of hospital cost that is based on the hospital charges and hospital cost to charge ratio. And we pay out 80% of that difference. We believe, again, this is a fairly old policy and outdated, that initially that hospital-specific outlier threshold was calculated so that about 5% of payments within each hospital would be outliers. We have not tested this out, but I think it is probably safe to say that after a decade of not adjusting that amount, the initial intent of that 5% has probably been lost at this point. And I do want to point out the footnote at the bottom here. While today's presentation is focused on inpatient, we are excluding from today's discussion the psychiatric and SUD distinct unit reimbursement that was recently updated to be effective this past July. All right, next slide. So some of the challenges of the current reimbursement methodology, I will note that this is from the main care and department perspective, and we could list a lot more here, and there's probably not consensus on all of these items either, but consistent with our evaluation of our rate reform system and the recommendations we received from that evaluation that was conducted in 2020, 2021. These are some of the challenges that we currently view. And I should also say that this is also in the broader framework of the principles and process for rate reform that were set forth in our rate reform statute, which we colloquially refer to as Chapter 639, although that's not the most precise citation anymore. All right, so looking at acute care, as I've already noted, the reimbursement is outdated. That is a big reason why we are here with you today, because we recognize that we do need to update the methodology. I'll also note that not all acute care hospitals are currently treated the same across these reimbursement methodologies. Rehabilitation hospital. So a flat discharge rate, one could argue that if there are changes in patient mix or the cost related to individual patient acuity, a flat rate for everyone does not necessarily do the greatest job of accounting for those differences. And again, that rate has not been adjusted for a number of years. And then common to both of these hospital types, as well as others that are beyond the scope necessarily of today's presentation, we don't have a mechanism for rates to keep pace with inflation. Part of Chapter 639 requires that we do that moving forward. There are some aspects of value-based payment here and there, but we would like to strengthen that relationship generally. As I noted, there is significant revenue from supplemental payments, which are not directly tied to current utilization and value for the most part. And then I will also call out that, as I noted before, we have components of the current system that relate to cost settlement. Generally speaking, cost settlement provides a limited incentive for cost control. There is also a relationship between cost settlement methodologies and variation in the system. It is pretty common for Medicaid, generally speaking, and for main care specifically, to hear about the shortfall between what we reimburse and hospital costs. Sometimes that's painted with a little bit too broad of a brush because per definition, we absolutely cover costs in a number of circumstances. But I did want to note that while you often hear about Medicaid shortfalls, we don't often hear about variation in the costs themselves. And that variation can be significant. And there is not often much discussion as to why that variation exists or whether or not it is appropriate from hospital to hospital. I will also note that cost settlement can be administratively burdensome or is really administratively burdensome for providers as well as for the department. And I'll also note that having a reimbursement methodology that is as complex overall as ours is, and as many hospital reimbursement methodologies are, can also be of significant burden to administer and also to deal with on the hospital side of the equation. All right, and with that, I will turn things over to Steve from Burns & Associates. Thank you.
Thank you, Michelle. And thank you again, Jessica. So Michelle did a really good job there kind of outlining the current state of affairs. So I'm here to talk a little bit about right now where things stand, what direction main care is kind of proposing to go. I'll just note real quickly that this is not a radical departure from what's going on right now. There's just a few minor tweaks here and there to how things are done. We wanted to make things, to some of the things Michelle said, we want to make it so that things can be updated on a regular basis going forward and maintained, as well as keeping it in a simplified manner as possible. I know that's maybe an oversimplification because hospital reimbursement is a complex system, but keeping it as understandable and straightforward as possible. So to that end, as to the hospital rates, currently MaineCare is proposing to adopt Maine-specific base rates that will vary by acute care hospitals and rehabilitation. So for that single freestanding rehabilitation facility, they will have their own base rate. All other acute care facilities will get a single base rate inclusive of operating and capital costs. So just right there, just to note that Michelle is kind of keeping track of their currently capital costs are cost settled. And right now the proposal is to roll the reimbursement for capital costs into a prospective payment system. So eliminating that burden of the annual cost settlement. And we'll talk more about that in a little bit. So otherwise, MaineCare is pretty much proposing to largely align with the Medicare Inpatient Prospective Payment System, or IPS, some people call it. In particular, we're going to continue to use the DRG grouper system. This is not a change. This is something that's been going on for a long time. And currently there's more than 750 DRGs that are eligible for payment. However, MaineCare is proposing to adopt Medicare's relative weights, primarily because this will allow for future updates and ease of maintenance. MaineCare is choosing to kind of move away from the Maine specific weights at this time because of the amount of work. I mean, let's all face it, 10 years ago or 12 years ago, somebody developed these and they're like, oh, we're going to do this. And then they've been sitting there now for 10 or 12 years. And it would be good to move to something that could be regularly updated. Doesn't mean in the future that we couldn't go back to something like that, but for this time, for ease and transparency and moving forward, adopting the Medicare relative weights, which get updated annually by CMS, is the way that everybody's going. There will continue to be a DRG, or there will continue to be outlier payments, but rather than hospital specific thresholds, we're moving to what many people call a DRG based outlier payment. So there will be a single threshold applied across all DRGs. So the higher cost DRGs will have a much harder time getting to the outlier payment. But again, it's a very similar methodology. It's just a single threshold amount picked for all hospitals. Very similar to the methodology that Michelle outlined. Next slide, please. So when it comes to some of the information moving forward, we'll be referring to things by peer groups. MaineCare just intends to kind of adopt a methodology that is based upon facilities with similar delivery systems and cost structures. The most basic of these is, in essence, taking the acute care facilities and splitting them into non-teaching acute care facilities and teaching facilities, those with approved medical education programs. The other peer group that will be used will be the rehabilitation peer group. And this is inclusive of any freestanding hospital designated as a rehabilitation facility. And currently Maine only has one facility of that type. This will just be used to differentiate. There's a few different, in essence, the primary difference is the teaching programs have graduate medical education. And some of you may have noted on the prior slide that we didn't say that the base rates were inclusive of that. So, and we'll see that here in a second as well. So next slide. So for the base rates, currently MaineCare intends to apply the base rates to determine the reimbursement for hospitals. All of the base rate amounts will depend upon the availability of funding. So they'll need to secure the appropriations, and reimbursement is subject to upper payment limitations, or UPL, you may have heard, the standard set by CMS. So the base rates are being developed using calendar year 22 utilization. These base rates are intended to be inclusive of capital costs as well as operating costs. Again, just reinforcing capital costs will no longer be subject to cost settlement. For the teaching hospitals, this is the reason we have the separate base or peer group for teaching hospitals. A hospital-specific graduate medical education add-on will be applied to their base rate as well. GME costs also will no longer be subject to cost settlement. These will be made in a prospective payment manner, just like capital. So essentially, all hospitals will have a rate which will be equivalent to their base rate plus any GME add-on, graduate medical education add-on, if applicable. So the inpatient reimbursement formula will remain as it is in effect today, which is taking the hospital's rate times the DRG's relative weight. As current, in cases where an individual DRG payment or stay meets a threshold of having extraordinarily high costs, then those cases may be eligible for an outlier payment in addition to the payment outlined here. And we'll talk about that in a second. Before we do that, we're going to go over a few of the issue or the things we've observed with the changes with the DRGs. So next slide, please. So just as a little background, just make sure everybody that we're level set and everybody's on the same page. Diagnosis related groups or DRGs. These are assigned upon discharge and based upon the diagnosis, primary as well as all secondary diagnosis, and comorbid conditions, as well as other factors related to care needs, age, sex, and other factors. Each DRG is assigned a relative weight, or weight, we just kind of get rid of the relative part, used to determine the payment for services. Additionally, DRGs are assigned to major diagnostic categories. These represent broad categories of conditions that are related, usually based upon condition type of body region. We only bring that up because there may be some reporting in the future that MaineCare does, and they may report out on MDCs, and mappings between the DRGs and the MDCs are available and will be made available in the future. So what does the DRG relative weight represent? What does it do? So these relative weights, which are determined by CMS annually, are used to estimate the relative resources required to care for individuals obtaining these particular services. And that allows for an adjustment to the reimbursement proportional to those resources required. DRGs with higher relative weights, typically that represents a intensive resource utilizing service as compared to those with lower weights. Some of the standard examples are craniotomy, or that's for all of us that aren't doctors, that would be brain surgery, versus a baby born to a healthy mother, a healthy baby born to a healthy mother. Those two ends of the spectrum kind of represent kind of high intensity services versus low intensity services. Again, just to restate, Medicare determines and updates these DRG relative weights annually, usually published for use beginning in the federal fiscal year each year, October 1st, by CMS. So that's the advantage here. This is one of the primary drivers of going to picking the Medicare DRG weights. These are maintained and updated on a regular basis by CMS, allowing MaineCare to, for lack of a better word, not do the footwork. Now, these are national standards, and they are based upon the entire nation's use of these services. So the limitation is they're not specific to Maine. But at this time, the decision has been made to go with these because of the ease of updating and future updates, to get out of this cycle of, oops, we forgot to update things. It's been a decade. We need to update things. So next slide. So I put on here a few examples of some of the DRG weights. Right now, the most recent one that we've seen, the relative weights range from a high of 36.1 for DRG 18, that's a T cell treatment for individuals, to 0.2 DRG 795. That is a normal, healthy newborn. So you can see that, in essence, if you compared these two, if I can do my math correctly, the T-cell treatment would get approximately 180 times the payment of the normal newborn, because 36 is 180 times greater than 0.2. So that shows you the relative change. So if it was just, $1,000, you get the base rate times 0.2 for one and the base rate times 36 for the other. And we've included here a sample of some of the DRGs, just starting with the lowest numbers and their current assigned weights. As you can see on here, the one that I always pick on a lot myself is, did we get no, craniotomy didn't get on here. It comes a little later, I guess. But you can see heart transplant, 28 is its relative weight, DRG1. Obviously, that's pretty intensive service. So let's look at the next slide, please. So here, just to illustrate, we've put side by side the updated Medicare relative weights versus the current main care relative weights. And this, we've selected, I think this is 20 of some of the most utilized DRGs during calendar year 22 for the main care system. As you can see, if you go through, there's some highlighted section here. Some of these, you're getting dramatic increases. I don't want to just focus on those, because if you look at the first one, DRG 177 or 189, the respiratory related DRGs, those are decreases. So we're seeing movement both ways. Some are increases, some are decreases. But again, these are just reflections of the overall resource intensity of the services. We feel that some of the increases are well worth the time, but again, I can't stress it enough. The point is to get more up to date with these weights and continue to keep these weights up to date for future use. So next slide, please. So I mentioned outliers a little bit ago, and I just want to kind of go through that a little bit more in detail. Currently, and just to reiterate, MaineCare's goal is to maintain an outlier payment policy. This is in recognition that some cases across all DRGs, comparatively speaking to the other cases within each of those DRGs, can be considered high cost. And this could even be for a normal newborn case. So the outlier determination compares the overall cost of the case against the threshold to determine its eligibility. So the threshold value is the base DRG payment plus a fixed threshold determined by MaineCare. For determining an outlier's eligibility for payment, the total cost of the claim. Now, this is important here because currently, I believe the current outlier is based upon charges, and we're moving to a cost base. And as everyone might suspect, charges and costs don't always move in lockstep with each other, especially if we look at some of the cost movements over the last 3 years. Because of the public health emergency, we saw some dramatic changes in cost and not necessarily the same dramatic changes in charges. So we feel cost is a more appropriate determination. So the total cost of the claim minus that threshold value calculation is determined. If that amount is greater than 0, then an outlier payment is made that takes that outlier determination value times a fixed percentage. So the outlier payment is made in addition to the base DRG payment as well. And this is very similar to current. The only difference is moving to a single threshold value for all hospitals and using costs of the claim. So the proposal is to apply this cost-based threshold, not charge-based, and this aligns with the Medicare methodology. This is very similar to what Medicare uses. Maine will be choosing its own threshold value, though, different from Medicare's value. Again, targeting that about 5% of the reimbursement should come from outlier payments. MaineCare currently supports that hospital-specific charge-based system. But again, as Michelle very aptly pointed out, that has a potential for providing for some inequities in the system. In other words, if if your facility if a facility tends to charge higher amounts and get more intense than another facility that tends to do more routine type services, the ability of that routine hospital to get an outlier is lessened with a charge-based system. With this system, it's really taking and individualizing it at the DRG level and allowing more outliers to be paid across all the DRGs. Where in a charge-based system, you tend to see them group into the higher intensity DRGs. So, next slide. So the last thing I have to talk about today before I pass it back to, I don't remember who, but Jessica will tell me who, is just to go through a methodology example here. So I just want to take a second, and this just really kind of shows what's currently happening versus what we're proposing to have happen for the acute care and rehabilitation reimbursement. So for the acute care, currently there's a hospital rate, and these are unique by facility, plus a capital expense add-on, plus the GME add-on, if it's applicable. All of that is added up and multiplied by the main care DRG relative weight, that one that's been outdated for 10 years. Also, the outlier is checked to see if the case is eligible for that, and if it is, the outlier payment is added on as well. And just a reminder that the capital and GME expenses are cost settled on an annual basis. So these payments are made out on a regular basis, but then at the end of the year, everything gets cost settled. So you were paid $1 million for capital through your DRG discharges. Your capital cost was $980,000, so you owe us money, or it was $1,200,000, so we owe you money. So that all happens at the end of the year. In the draft model, there's going to be a base rate plus GME, if applicable, multiplied by the Medicare DRG relative weight, plus, if applicable, the outlier payment. Again, all cases will be checked for outlier status. GM and capital cost is included in the base rate. So GME and capital cost will not be cost settled. So again, the hope here is to simplify things. And these base rates will be determined based upon available funding at the time. For rehabilitation, again, the current model is, as Michelle mentioned, it's per discharge. So there's no accounting for intensity, duration, or what the individual who's being discharged actually has happened. All GME and capital costs are settled annually for these services. In the proposed methodology, there will be a base rate applicable. GME will be added on if it applies, and that amount will be multiplied by the relative weight. So now we're giving some credence to the difference in intensity of services, even in these types of settings. Outliers will be checked as well and paid if appropriate. GME and capital costs under this situation, just like acute care, will not be cost settled. So aligning with Medicare, main care will also be updating and revising the DRG weights on an annual basis. In the silent part of that we don't really talk about, but in alignment with that is based upon available funding, they would also update the base rates as required to ensure that funding targets are met. You know, if all the DRG relative weights go up, then something's got to give if Maine doesn't have any more money to spend. So, so all of that will be done on an annual basis in the future. So at this time, I'm going to turn it back to Jessica because I don't remember who I'm supposed to turn it back to. I apologize. So thank you.
Thanks, Steve. Next slide. Julie will take over. Thank you, Julie.
Thank you, Jess and Steve. So earlier this year, the Maine State Legislature passed LD 1104, which is a resolve to review the Maine Care readmission protocol. This LD requires the department to review our current rules and reimbursement for hospital readmissions and report back to the legislature with our findings and recommendations for development and next steps. This study requires a special focus on patients who are discharged against medical advice and patients with substance use disorder or co-occurring substance use disorder and behavioral health disorders. Can I have the next slide? Thank you so much. So this LD actually ties in really well with our current hospital rate reform efforts. So policy currently exists in Section 45, which speaks to discharges and how related claims are impacted when a member is readmitted to an inpatient setting within 14 days of their initial discharge. So there are numerous exceptions to this policy, such as chemotherapy, planned hospitalizations, critical access hospital. So many exceptions, which we are happy to talk more about down the road. But in short, we're just looking at the overarching readmission policy for now. MaineCare is reviewing this policy with notable considerations to further align with Medicaid practices and meet the requirements set forth in LD 1104. So multiple boards with limited stone. And as noted in the slide, we're exploring a few areas of development within the policy. So this includes, but absolutely is not limited to, the readmission window, which again is currently at 14 days. What actually constitutes a discharge? We're exploring exemptions to the readmission policy and different exceptions, different types of hospitals that are held to the policy, who's impacted and who's exempted, readmission penalties, what happens when folks are readmitted. And we're also exploring, of course, equity and operational considerations impacted by the current policy and draft changes. Could I have the next slide? So for members discharged from inpatient hospital settings, which in this case does not include critical access hospitals, MaineCare reimburses hospitals for each day following the 10th day a member remains in the care of the hospital while awaiting placement elsewhere, nursing facility. So while folks are waiting to be placed in that nursing facility, MaineCare reimburses any and all days after that 10th day. And annually, the reimbursement pool for that for hospitals across the state is capped at $500,000. And as folks may be aware, that is set to end at the end of this year. So December 31st, 2023, that pool is shifting per law. And as the current days awaiting placement process is expiring at the end of the year, the department is very aware of that and recognizes the need to continue reimbursing hospitals for services provided to members awaiting facility placement following their inpatient discharge. So on that note, we are exploring the possibility of implementing, exploring a few different possibilities, but we're looking at implementing a set daily rate, which would apply to eligible hospitals statewide. The department is also reviewing alternative approaches to the current 10-day waiting period. We're actively running tests to see what alternative approaches are operationally feasible, and are excited to see the results of those tests and look forward to discussing our findings in the future stakeholder meetings to come. So stay tuned. Back to you, Jess.
Thank you, Julie. As we've been talking about earlier in the presentation, we're going to hold some future meetings, and we wanted to share with you what the topics will be in some of those future meetings. So we will be discussing outpatient services, days awaiting placement, readmission policy, individuals in the emergency department, and the cost of living adjustment. So when I say we'll discuss it, we've kind of done like some of these topics on a higher level today, but we'll be able to share additional information in some future meetings. Next slide. So we've reached a part in the presentation in which, although this is more like kickoff or kind of sharing some of our basic information for the inpatient services, not the official comment period in the draft process that will happen later on, like maybe late spring. We'll take some questions regarding this presentation now, and I just want to go over how you will be able to ask your questions. So we would ask, if you have a question about this presentation, please raise your hand. We try to ask people to limit their comments to a few minutes. And again, this isn't the avenue for the official public comments or questions, but you can submit some questions to me after this presentation, and I will be putting my email in the chat. So to raise your hand, there's the reactions or participants function below. If you're on a tablet, you can Alt-Y to raise your hand, toggle on and off. And if you are on a phone, please press *9. So at this time, if you have any questions about this presentation, please raise your hand. Okay, thanks. I was just going to say, while we're waiting for someone to have questions, I know that we have shared a lot of information, and I did post the website in our chat, and please go there and you'll have access to this presentation where you'll be able to have some more time to absorb that. Lisa?
Hi, Lisa Harvey McPherson, Northern Light Health. I apologize if I missed this. Can you clarify the payment for critical access hospitals? Will they continue to be reimbursed at 109% of allowable cost?
Today's presentation is just about acute care, hospital, inpatient, as well as rehabilitation. So that's all we're prepared to speak to today, Lisa.
Okay, is there a plan to focus on critical access hospitals at some point?
We'll address critical access hospitals at a subsequent presentation.
Okay, thanks.
Thank you, Lisa. Skip?
Hi, yes. I have a question about the GME being a fixed amount in the reimbursement model, and trying to draw, physicians into the state and how that would limit the ability. Can you speak to that?
As I noted in the chat, and Jessica might have said this at the outset, and I may have missed it, but as you noted, even if you didn't look in the chat, we're not talking about actual dollar amounts today, but just methodology, and so we'll be getting into more discussion regarding investment into the system, and I think that will be pertinent information. Skip, to your question. So also, as Stephen had noted, obviously we're looking at the GME costs for the teaching hospitals, and are having conversations to ensure that the methodology is adequate. Stephen, I don't know if you'd add anything else to that at this time.
No, I don't have anything to add. Thank you, Michelle.
So while we're waiting again, I just reminding everyone to copy down the website information in my email that I've posted in the chat. So if, as you're reviewing stuff later and you do want to send in a question to me, you will have my email, and also by copying down the website will give you faster access to the recording and the PowerPoint presentation. Go ahead, Al.
Thanks, Jessica. It's Al Swallow from Maine Health. First of all, thank you to this group at the state for trying to tackle a pretty significant challenge here around reconfiguring the hospital payment structure. As you all noted, it's been a long time, and a long time coming, and needed for a long time. Michelle, I think you made a comment about costs and paying costs. And certainly components of the structure today pay at cost or even above cost. But I just wanted to understand, though, is there a target here overall to get to cost, or are we recognizing that even with these adjustments that there likely will still be a shortfall to actual cost overall? It's not a goal or principle you're trying to get to, is it?
So I'll just say, and Stephen mentioned this, but our investment into a system, and this goes for all services, is limited by appropriation. And so there are broader discussions that need to happen in order to figure out what we can target. Also, unlike for some services within MaineCare and Medicaid, as Stephen also noted, there's the upper payment limit. While that can be related to cost. You generally don't want to get to that line too closely, or else if costs actually go up a little bit beyond what you did, then you'll be in misalignment with that policy and face significant additional costs. And so that's another consideration as we look at investment in the system, are those UPL limits.
Okay, thank you.
Giving everybody a couple of minutes to see if there are any more questions about the presentation today. How about while we're waiting, I'm going to go ahead and go over what our next steps are for this process. The department's going to continue their rate reform efforts. We will continue to have some other public meetings like we've discussed on those topics. We are hoping to do a public presentation of draft rates and the rate methodology in 2024, probably maybe late spring. That after that meeting is when we will have the official written comment period. Then we review the comments and it will be posted on our website. And we are targeting the things that we discussed today to have a 7/1/24 effective date. And again, there's my name and my email address at the bottom of the presentation. If anybody has any questions. At this time, does anybody have any questions that's on the call? Go ahead, Al. Al, you're on mute.
Thank you. Thank you. And I don't need to get into this in depth, but I just want this to be a question that we sort of deal with at some point through this process. And it's around the tax side of this. And so it was mentioned, I think, just in passing. Michelle, that slide you did was a really good one to try to get it all on one page, as complex as it is. It doesn't mention taxes on there. And the whole issue of cost and cost payment or cost shifting and taxes, I just want to know what the department's perspective is on the tax itself. And if you would agree that when you look at that page, it's hard to consider that page without the tax side of it. And so, when we think about what we get paid, if what we're getting paid is dependent upon how much tax we pay, there's a gap there that's not really funded. And again, some of this gets into this cost shifting discussion where purchasers and others pin us down on what we get paid, what's being cost shifted, and there's still a lot of payers out there that don't believe there's such a thing as cost shifting. Yet when we have a big tax, in order to get paid what we get paid, seems to me that should be part of the equation, even if it's not explicitly on your page like that.
Fair question, Al, and I will acknowledge that taxes are certainly part of the equation nationally. This can be a thorny topic with CMS at times, and they've had proposed regulations and actions in that regard to ensure that there is not a system whereby each hospital can be assured that they will get reimbursed specifically for the amount of tax that they put into the system. So that is something that we're very aware of and careful about. Similar to my answers to other questions regarding level of investment and if we're targeting costs, along the same lines, the scope of today's presentation is really not on the tax side of things, but I hear you that we acknowledge that that is part of the broader equation.
Great, thank you.
We really appreciate everybody being engaged, and we welcome you to ask any questions about the presentation. Going to give you another minute, and then if no one has any more questions about the presentation, then we will wrap up. It's looking like we have no more takers, Michelle. Do you have any departing words as we close?
Just appreciate your time here this afternoon, and we will be in touch soon. Thank you very much.